And we're so fortunate in our area of Central New York to have a patient advocate. And Dr. Kussin had been a practicing gastroenterologist for over 30 years. We're very fortunate to have him with us, and he has produced a book, and he is a consultant to anyone who needs help also in navigating and having more difficulty with the system. So Dr. Kussin, we welcome you. Thank you.
Thank you. The thing about New York State, just to start in and following up with Mrs. Myers, she's right. The Kaiser Permanente states that 60% of people have no idea about the provisions of ACA. And that won't be true of this crowd because she did such a wonderful job in introducing people to it and amplifying the knowledge. However, about New York State still hasn't even decided it's participating in its health exchanges. It's leaning toward it, but it is one of the states, in fact, the only state, that says, well, we're not so sure. The state of state exchanges, for those people who never had insurance, who now are available for it, 35 million people across the country are now going to be enfranchised, have the inalienable right of having their health protected, are going to meet pure chaos in January of 2014. And New York State would be a good example of it because it hasn't even decided whether or not it's participating in it. Insurance premiums for those who are in private insurance already are skyrocketing. It's sad, but it's true. Insurance companies, to my way of thinking, are evil. They're evil. They're evil incarnate. They've shown themselves to be evil. They've acted in a fashion against the interests of those people who pay the extraordinarily high amount of money in order to be insured in this country. They should have no role in it, but their role, as Ms. Myers mentioned, was quite supportive because of the gains they're going to make. I think there should be a single payer. I think there should be no fee for service. I think profit should be eliminated, unreasonable profit should be eliminated from doctors, hospitals, the healthcare, pharmaceutical industry, and the device industry. And what are you guys going to be protected now with insurance, even if you have to pay a little bit more? New York State puts a cap, one of the few states, happily, that caps private insurance from increasing its rates over 9%, but across the country they're going up 30% in anticipation of the Affordable Care Act, which I support. It is far from perfect. And in 2014, it's generally acknowledged that throughout the country it's going to be a very, very bumpy ride for those who are uninsured, for those who are insured. It affects every aspect of your care because of the Affordable Care Act, and because of the troubles in medicine, the administrative difficulties, the emotional difficulties. Increasing number of doctors, now the majority, 30% of all surgeons are employed. Once they become employed by a hospital, they become less responsive to individual patient needs. The waits will be longer, the visits briefer, and the information, it will be tainted by outside influences on physicians' decision making. So what is it that we're now insured for? It's generally considered in the United States we have the best medical care in the world, and that we don't pay very much for it. Across the world, in the 16 economies, advanced economies like ours, we are at the bottom in almost every metric of healthcare adequacy. If you're a fetus in a womb, you're less likely to be born. If you're born, you're less likely to make 5 years old. If you reach adulthood, you're less likely to be 65 than almost anywhere else amongst advanced economies. And we pay 3 times as much for it. If you're a 26-year-old person today, earning about $35,000, $36,000 with the anticipated arc of income and without an anticipated increase in healthcare spending, and there will be, that individual, out of their pocket, over their lifetime, will spend $2 million toward their healthcare, out of pocket. How can that be? It's a combination of their contribution to their healthcare plan, the increased Medicare tax, 1.43%, the fact that 1 out of every $5 we spend in this country is for medical care, and you're paying those taxes, and you're paying 1 out of every 5 of your taxpayer dollars toward health care, and Medicare fees as well. The benefits also that come out of your pocket are those benefits, because when your employer puts in $6,000 toward your health care, in addition to your contribution, your deductible, and your copay, that is coming out of salary. Employers really like to increase your health care benefits because it's a tax advantage to them and to the employee. But health insurance costs out of pocket have gone up 140% in the last 10 years, but pay has only gone up 30%. That's why. They're not perks, they're not giveaways. You're paying for your benefits, and you're paying out of your own pocket. And it comes to $1.8 million. So, number one, our healthcare system is horrifyingly broken, and we're paying a hell of a lot for it. And so with the Affordable Care Act, there are undeniable improvements that Ms. Myers so nicely explained regarding the improvements of health care. But the basic things that make our healthcare system so really terrible are going to maintain themselves because the vested interest is in maintaining the status quo. Just in Medicare, the $800 million that the government puts into Medicare and Medicaid services is equal to energy, education, transportation, Treasury, Homeland Security combined. And the industry is a $2 trillion industry. And so there's a lot of interest, and the interest is maintaining the status quo, and the status quo will be maintained, as well as the paucity of really good care. And I wrote a book based on my experience as a patient. And the idea was that people are not taken care of as well as I was taken care of because I'm a doctor. I knew everybody who was taking care of me. I knew their strengths, their weaknesses. My opinion counted, my dignity counted, and I was treated that way. And when it wasn't, I demanded different. I fired one doctor right on the spot. You're out. You ever do that? Should. You don't. Why don't you? Well, no, the book did well. Top 10 health book of the year 2011 that ran into 2012. The New York Times reviewed it, and I've had a lot of fun with it. It wasn't enough, so I opened up something relevant to the Affordable Care Act. It's called the Shared Decision Center. Shared decisions are part of the Affordable Care Act, and I'll go into that briefly. But medical care, as it's administered in the United States, and as it's going to be administered into the foreseeable future, I suspect 2 or 3 more generations, is not geared to the benefit of those to whom it should be aimed, that is, the consumer. We're remarkably bad healthcare consumers. We'll shop for a plasma screen TV as if it makes a difference, where only 5 companies in China make all 50 brands. They're absolutely indistinguishable one from the other. And yet we all think every doctor and every hospital is the same, and they're diametrically opposed in their interests, doctors and hospitals, and terribly different within each sphere. One doctor can be great and the other poor. I mean, here's a little fact. Almost half of the doctors you see are not as good as the other half. Now, that sounds pretty terrible, but that's math. And how do you know the good ones from the bad ones? Half are going to be above average and half are going to be below average. When it comes to your health, your welfare, how long you live, how well you live, that makes a big difference, and people don't know the difference. When you are stricken, you are cast ashore on a foreign island. You don't know the language. You don't know the culture. You don't have a map. You don't have the currency. You don't know the geography. And yet there you are at a time in your life, whether you're in an office for an important decision or in the hospital when you're severely ill, because the only way you get in the hospital now is when the illness is so severe it demands it, because everything is moving you away from being in the hospital. And once you're in the hospital, it forces you to get you the hell out. And so there you are on that foreign shore, and who's waiting for you? Us. You don't know us. You used to know us. You don't know us anymore, because the people who are waiting for you are hospitalists, intensivists, and people who you don't know and who don't know you. And even if they're smart, and you don't know if they're smart or not, you don't know their provenance, you don't know their names. They come up to the bedside, they introduce themselves, some of them wear a name tag, some of them don't. You don't know where they went to school, you don't know if they're smart, you don't know who they're working for, you don't know which interests are demanding or helping to make decisions. It's the hospitalist system. Your family doctors are no longer in the hospital with you. Specialists, like I used to be, would walk up to your bedside. Obviously, if you never knew a gastroenterologist, well, you've met one, and you don't know anything about me. And this is at a time when you're in the hospital, and to a degree, similarly, when you're in an office, where the ability to make decisions is going to be sorely challenged in the hospital because you're sick. Your mentation is being affected by drugs, the illness, people all around the bedside telling you A, telling you B, B disagreeing with C, and you're on your own at a time in your life when you can't afford to be on your own. And decisions are offered to you in a time when it's impossible to make a good decision because of the stress and the pressure, whether you're in the office or in the hospital. So this is not much of an island you want to be in. There are a lot of strangers whose skills and motives and biases are simply unknown to you at a time in your life when you really want to know what's going on. You all listen to the GPS satellite. No matter where you are, where you're traveling, if you're on a dark winter road and it says turn right, you're going to turn right. If it says turn left, you're going left. And you should. These satellites are 12,000 miles above our planet. They're traveling 8,000 miles an hour. And yet, what do? They know exactly where you are within a few feet. Doctors really don't know you. They don't even know of you or about you. And the fact that even if they do, the doctor you see tomorrow is completely different than the doctor you've seen today. They change so quickly. No one can take responsibility for you that way. So they don't know where you are. They don't know where you come from. They don't know what's important to you. They don't know your priorities. They don't know your tolerance to risk. They don't know where you are on income. They don't know how much insurance you have. They don't offer information about how much things are going to cost. And so where a GPS knows exactly where you are to a pinpoint, your physicians don't know where you are. They're on the North Pole, you're on the South Pole. The GPS knows which way you're traveling, how many miles an hour you're going, the obstacles along the way, and the GPS will reroute you. Doctors have no idea where you're going to be tomorrow, depending on the tests that are done today. And the obstacles, which are almost inevitable, you're going to reach them head-on collision most of the time, and it's only get rerouted after you've already had the collision. So with the GPS, you listen to it, and you should because it's science, but you treat doctors as if they're like a GPS satellite, based on the hard science that GPSs offer. Doctors are not scientists at all, and medicine is not science at all. Only a very small amount of medical care is evidence-based, and that which is said to be evidence-based is found to be full of bias, full of industry conflict, and full of bias. It would be nice in time to move toward evidence-based medicine, but now the shift is even away from that. It's toward personalized medicine through genomics, through shared decision-making, part of the Affordable Care Act, which is what I'm doing in the office here locally and now nationally. And I think that it's important to understand that doctors are not to be listened to with blind obedience, because half of them are not as good as the other half. Your ability to make a decision while sick is certainly compromised, and the pressures under which you work to make a decision and the doctor's work toward making you make a decision are not at all the same. I mean, if you go to a Chinese restaurant, you're going to look at the menu and you're not going to say, I want a BLT. It ain't going to be on the menu. So when you go to an orthopedist, do you think you're going to get a non-orthopedic approach? Any non-orthopedic approach will be only mentioned to disparage it. If you come to me as a gastroenterologist, well, not me, I was really very good. My heart beat with a purity of essence of soul. The gastroenterologist is not going to tell you to have a sigmoidoscopy or send in a stool sample for occult blood as a reasonable alternative to colonoscopy. They might, but they're only mentioned only to disparage it. Doctors recommend what they know how to do. Doctors recommend what they were trained to do, like to do, or paid to do, and usually, most of the time, get good, pretty good, sometimes better than average results. That's what they're going to tell you should have. When you go to Midas, you get a muffler. When you go to a gastroenterologist, you're going to get a colonoscopy. When you go to a cardiologist, you're going to get a cath. If you have a torn meniscus, you're going to get a meniscus repair. A torn rotator cuff, a rotator cuff repair. There are alternatives. And that's what shared decision-making is about. From the tried and the true to the latest and the greatest, there is a spectrum for almost every drug, disease, and diagnosis. And there's plenty of time to investigate it. When a doctor tells you you have cancer, you're ready to lie down and sign up for anything. You're put under pressure, subtle but real. The decision is a hot decision. It's made in the context of fear and anxiety, not wrought by the doctor, but wrought by the diagnosis. And you're going to rush to make a diagnosis, and you're going to have a regret, misunderstandings, confusion, suspicions. And although most doctors truly do work from their heart, the things that affect doctors and the bias that affect us are real, and they're pernicious. But they also happen to be unconscious in many, many cases. Because doctors usually mean and feel what they say, but they're working under a set of biases that have been well documented in the literature. And so to step back, realize you have time to research on your own or through shared decision making, which can't occur in a doctor's office. The idea of shared decision making is reaching a conclusion about your care that's based not only on medical science, because that doesn't exist, there are alternatives to everything and almost for everything, but also your personal priorities, your preferences, your risk tolerance. What risk are you willing to take on Tuesday for your scheduled back surgery when the alternative is spending a few months doing alternative types of care that at the end of 6 months both population groups are doing just as well? But the one on Tuesday is taking an immediate risk. The same thing for colonoscopy. 96% of you are not going to get colon cancer. And if you do, it's going to be a long time from now. And if you do, it's well treated. What risk of a perforation of a colon are you willing to take on next Wednesday's colonoscopy? Look, what's right for you may not be right for the person sitting across from you. What's right for you today may not be right for you 20 years from now. And medicine, to a large degree, ignores this, and you get the recommendations of your doctors, half of which are less good than others, all of whom are working under conflicts of interest, conscious and unconscious. And so, shared decision-making, which I'm actually probably one of the only people doing it on a community basis out of a dedicated building, not affiliated with the university, although I am affiliated with Utica College, but not directly through this, as well as having a national practice, as well as now working for a Chicago outfit as their medical director that's based on shared decision making, is something that is important for you folks in Central New York, all of us in Central New York, to realize that your needs are not being seen to, your priorities are not those of your doctors or your hospitals. Big news last week, big news, and none of you heard about it. If you did, you raise your hand because I'd be interested in knowing about it. Leapfrog, which is an extraordinarily well-regarded, nonprofit, unbiased foundation, has the regard of healthcare administrators, healthcare wonks all throughout the country, well known. They comment on hospital safety every year. Here in Central New York, we are happy and privileged to be surrounded by all the hospitals around us, do much better than average in this country. Oneida gets a B, Bassett gets a B, Rome gets a B. We're surrounded by wonderful, safe hospitals according to Leapfrog. Did you know that last week St. D's got a C and Fax and St. Luke's a D? The hospitals are working with the best of intent. I know that because I know the administrators and I know my colleagues. I know their hearts, I know their intent. They want to deliver good care. They want to deliver safe care. And they're working toward that end. But you're not going to read about it. The OD is not going to publish it. I tried. The TV, and I'm on all the channels locally, are not going to talk about it. I tried. Not in a way of, whoa, you guys are living in a pit. It's just rather, let's learn about what it means to be in a city where we get C's and D's and everyone around us is getting B's. It doesn't mean the hospital is a bad intention. It doesn't mean the doctors are bad intention, but there's something to learn from it. So medical care is something that we should be pleased to have and lucky that we have insurance. But if I told you just another story before I quit, if you woke up tomorrow morning and saw that a jumbo jet crashed and all 500 aboard perished, it would be horrifying, it would be terrible. It would be news for a week or more. But there wouldn't be time, because if the next day another jumbo jet crashed, and the day after that another and another and another, every day of the week, every week of the year, 500 people in a jumbo jet crashing to earth with no survivors, and you had an airplane trip scheduled, you gonna get on that plane? You're not getting on that plane. Even though there are 50 or 60,000 flights a day, only one fell to earth, you're still not getting on that plane. The same number of people, according to the government, covered by Medicare only, we're only talking about 65 and over, die every month due to poor, negligent, inaccessible, subadequate care. 15,000 a month, the equivalent of a jumbo jet crashing to earth every day. You don't know about that. It happens behind walls. And someone dying from a heart attack or pneumonia or a surgery that they needn't have died from, or died in the emergency room waiting to be seen, or after they were discharged with reassurance, that's no one's idea of a headline. But the numbers are the same. They come from Luncheon Leap from the Harvard Public Health School. And it's a well-established statistic, and it has been verified by the feds. We're only talking about 65 and above. We're not talking about 0 to 64. We're just talking about people 65 and above. And we're only talking about dead people. We're not talking about those who are psychologically traumatized, disabled, or bankrupt. Bankruptcy is the leading cause in this country. It's not mortgages, it's not college debt, it's not credit card debt, it's medical debt. So this is a bad medical system that's going to continue to be bad despite the Affordable Care Act. It'll just be 35 million more people have access to it, which, by the way, is going to put a lot of pressure on you people who are insured, because you have 35 million people with pent-up demands coming into the system, in a system where there'll be about 60,000 fewer physicians in the next few years to take care of them. And most of those physicians are going to be employed. And once private entrepreneurial instincts to please the customer are gone, there'll be a palpable difference in your care. So I think it's great. If there's nothing else about the Affordable Care Act that was important and made it worthwhile and made it a truly groundbreaking piece of legislation, is the fact that in a country where we assume that life, liberty, and the pursuit of happiness is a given, without health insurance and without access to health care, regardless of its quality, you don't get life by definition. You don't get the pursuit of happiness if you're pursuing chronic medical needs that are being unattended. And you're certainly not going to be happy if you're sitting at home debilitated by conditions that would benefit from therapy. And so if for no other reason, 35 million, 95%, not 100% of Americans will be insured. The rest of us will pay a price. We will pay higher premiums. We will have less quality care into the future because physicians are dropping out and they're becoming employed. And medical care itself and the institution of medicine and its biases and its strengths are all going to persist as they are now because of the vested interest economically in the system as it exists. So yes, the Affordable Care Act is terrific. It's no one's idea of a good system. It's everyone's idea, which should be, I think, everyone's idea of a better system, a fairer system, a more equitable system in this country where, unlike these other 16 economically advanced societies where medical care is a right, and medical care is better, and people live longer, get care quicker. So the shared decision making is my part of the Affordable Care Act, And I'm happy to be actually one of the leaders in it. And I'm happy now that people get on the website, actually from all over the world, but particularly, of course, the United States. And I'm happy to be working for a company whose basic goal is to make healthcare costs completely transparent, which they're not. You can pay $5,000 for an artificial hip, you can pay $120,000 for an artificial hip, and it can be a difference of 10 or 15 miles. And there's no difference in the quality. That just came out last week from Sibelius. Go online, look up 100 common conditions, costs, and now you'll find that they're now public. So this company works under transparency, competitive bidding, shared decision-making, personalized medicine, and patient-centeredness. This is what the Affordable Care Act hopefully will become. It ain't there yet, as denoted by New York, which still hasn't even made up its mind, and no state is ready for January 2014. No state is ready. They haven't hired the people. They don't know what it's going to look like. They don't know how much it's going to cost. They don't know who's going to administer it. They're trying, and they're in good faith. It's going to be a very bumpy year, despite the qualities of the Affordable Care Act. And that's it. Thank you.